question is to Dr. Malhotra. Suppose, sir, in some patient, FNAC is inconclusive and mammography shows BRAD 3 or 4, and in such cases, excision biopsy turns to be ductal malignancy. Then, in such cases, how to deal?
Could you just repeat your question?
FNAC is inconclusive.
You have a breast mass, basically.
Yeah, breast lump, and FNAC is inconclusive. Mammography shows BRAD 3 or 4, and excision biopsy has been done, which turns to be malignancy.
Well, you see, what we would do in these cases, if a lady presents to us with a breast mass with an inconclusive FNAC, well, we could we would basically remove the breast lump, send it for frozen section, and then proceed this thing. Otherwise, in fact, FNAC is now gradually going out of fashion, and core biopsy is the answer. But yes, I mean, if still it is not localized properly, it's inconclusive before you operate, if you mean to say. Then, of course, the only option is open up, send the lump for frozen section, and then proceed. Otherwise, core biopsy is better, not only because it gives you, more confirmatory data, but also you can do the ER/PR and HER studies on the core biopsy.
After excision, what will be the treatment modality? There is no lump, but the histopathology is showing ductal malignancy. Then in such cases, what to do?
Sir, I just want to.
Well, you see, if you have done, it depends. Basically, if you have done a wide excision, no, you have not treated it like a malignancy. You have just taken it out. Generally, a frozen section is also negative, and the paraffin section is positive. Is that what you mean?
No, sir. Lump is out by an excision, and it comes as a malignancy.
Okay.
And for that patient, what to do? In future, he may develop some.
What are the margins?
If the margins are negative, you treat the axilla as well, and then depending on the findings in terms of the size of the tumor and the nodal status, and the hormonal status, we give them medicines accordingly, whether they will require chemotherapy, hormone therapy, or targeted therapy, depending on whatever.
Whether we will go for radical or modified radical mastectomy and then radiation to axilla. Yeah, whole breast.
No, the radiation to axilla is a different issue. That will depend on the findings of the nodal status. So radiation is different. We will not.
Not go to radiation.
First the thing is that you have to complete the surgery. If it is a proper taken out lump, then you have to go for axillary
with negative
section.
margins.
Yeah, and if the lump is just incisional biopsy, then you have to complete that. If the patient wants the breast to be out, you can go for MRM also. So it depends like what you want to do, and surgery has to be completed first, and then we go for systemic treatment or RT, whatever it is.
I just want to make a comment, sir, on this. Sir, in the case if FNAC is inconclusive, I just, in my setup I'm using that. I also advise other people that we should use a core biopsy first before any excision biopsy. Because rather to use a core biopsy first before FNAC is good.
Yeah,
but directly going to excision biopsy without doing core biopsy, which is so easy and not traumatic to patient, is a must. They should not proceed to excision biopsy in the case, or incisional biopsy in the case where a core biopsy is possible and just a click away.
Absolutely. I think in fact it is. Core biopsies are replacing FNACs, so that's the first thing.
They give us the ER/PR status and HER2 status, everything they give us.
So that's the first take-home message, that you, instead of FNACs, one should shift towards core biopsies.
Second,
and in case you are, even then something you are unable to get it for some reason, then of course you have to excise. What we would do is we excise into a frozen section and then proceed.
Second thing, sir, he was asking that if this excision biopsy is there and he has already done a lumpectomy, if there is a margin is negative, then we have to ask the patient that we have to do a nodal dissection and then we will give the radiotherapy. Otherwise, and there should be no radiotherapy to the axilla, no whatsoever, if the axillary section is complete. Because it will definitely lead to the lymphedema and the problems. Yes, sir.
No, he's talking about axillary radiation.
I'm just telling you, axillary section if it's been done by the surgeon.
Yeah, I don't think, yes, absolutely.
Yeah, RT is not required to give to
absolutely. I mean, if the axillary dissection has been complete, you don't need to give radiation.
Radiation to axilla. That's harmful rather.
So, if there are no further questions, I think then we can conclude this session. I thank the speakers for their excellent presentations and the audience for a patient and interactive
I request the moderator, Dr. A.K. Malhotra, to felicitate the speakers. Dr. Shubhrata Das. Dr. R.K. Mahapatra. Dr. Shuchanda Goswami. I now request Dr. Pathak, the Secretary of ARSI, to please felicitate Dr. Malhotra.